Dr. Perimer, could you do you hear to us? Could you hear my voice?
I can hear your voice. Yes, I can,
Okay,
Professor.
thanks. Yeah. Okay. I will be the star, and firstly, I will introduce you first. Okay. Yeah. 那首先谢谢大家参与这一场的那个中午的 lunch 那 symposium 哈。那我们今天讲的题目是对这个体外震波的治疗啊，它用在伤口上面，特别是糖尿病组上面运用哈。那firstly, I'm Professor Yaron Guo from Taiwan. I work in Kaohsiung Medical University. And today in our lunch symposium section, we invite Professor Perry Mayer from Canada to give us a talk coding the extracorporeal shockwave treatment in wound healing. And I just should briefly introduce Professor Perry Mayer. Perry Mayer now is the medical director of the Mayer Institute and the Center of Excellence dedicated of treatment of the diabetic foot. And actually, his clinic is the most focused on the chronic one, especially for diabetic foot ulcer. He has numerous patient treatment in his past experience in his clinic, and quite famous and in the world renowned, and also been invited numerous international congress as the invited speaker. And he also current research project including a trial investigating the effect of a novel delivery system of a transport various molecular through the skin and wound tissue, and examine the effect of this transport system and on the proliferative and cell migration phase of wound healing. And today, he wants to give us a talk as his past experience. He has been more than 17,000 patients has been visited, and also have more than 15,000 visits been as the diabetic care experience. So we are welcome Professor Perry Mayer to give us the speech, also share his experience. Professor Mayer, please.
Professor Koh, thank you so much for that lovely introduction. And I know you have earned your professorship. You've graciously elevated me to professor. I am merely a doctor, and but thank you so much for that. And it is an honor and a privilege to be here this afternoon with you here at the Taiwan Wound Care Society Congress. We're here to talk about dermaPACE and what it can do for wound care. What is dermaPACE? PACE, or Pulse Acoustic Cellular Expression, is a proprietary form of extracorporeal shockwave technology. And this is technology that uses high energy acoustic pressure waves in the shockwave spectrum created through an electrohydraulic method. And the electrohydraulic method is the handpiece. And in the handpiece, there are pressure signals that are generated, that are transmitted through a liquid at the end of the handpiece and into the tissue. And we feel that this energy transmission into the tissue causes mechanical stress on the cell surface, and that deformatory effect on the cell surface, the stress of the cell surface, elicits this biological response at the neovascular level, and which promotes the healing. All right. So what is the mechanism of action of dermaPACE? So dermaPACE increases local blood flow. It enables leukocytes to transmigrate. So in other words, the leukocytes that are facilitated to pass through the vessels to allow them to get to the wound bed where they're needed. It increases, sorry. Oh, I'm sorry about that. Oh my God. It increases cellular communication or cytokine activity. Now, this is the signaling activity of all of the cells around the periphery of the wound in order to get them to come in unison or in a coordinated fashion onto the wound bed. It significantly upregulates proangiogenic and tissue regenerative proteins. So the growth factors are upregulated and in order to stimulate angiogenesis or new blood vessel growth, which then in turn, in combination with all of the previous effects, facilitates wound reduction and wound closure by granulation and reepithelialization, so cell migration onto the wound bed. So what do we use this for? Well, the FDA has cleared the use of dermaPACE for diabetic foot ulcers. In the rest of the world, you can use it for just about anything, any kind of wound. Diabetic foot ulcers, deep tissue injury, pressure ulcers, decubitus ulcers, ischemic ulcers, venous leg ulcers, burns, post-operative wound healing defects or incision line healing. We have a paper on that, and I'll present that later on in the talk to show its effect on speeding up incision line healing and reducing the peri-wound edema. And post-traumatic wounds, all very useful and wounds that we would experience in a day-to-day basis. So let's talk a little bit about diabetes and the incidence and prevalence. So the incidence of diabetes around the world hovers between 7 and 9 or 10%. Here in Canada, it hovers at around 8%, but certainly varies markedly amongst different populations within Canada and throughout the world. The prevalence also varies quite dramatically. And in Southeast Asia, where you're located, the prevalence and incidence are about the same as in Canada, but is going to go from about 7% up to 12% within the next 20 over years. That's a tremendous increase in the number of diabetic patients, and that translates to an equal number of diabetic foot wounds. So why is that important? Well, diabetes is the leading cause of non-traumatic lower limb amputations worldwide. Now, this is a well-known fact, but one that we all need to remember. 25% of people with diabetes will develop a diabetic foot wound in their lifetime. So remember, when the incidence and the prevalence rises so dramatically, you're going to get a quarter of those people will experience some kind of a wound in their lifetime, and we'll need to deal with that. 85% of diabetic lower limb amputations are preceded by exactly this kind of wound. And once you go on to amputation from after a diabetic wound, the mortality rate is extraordinarily high and approaches, 5-year mortality rate approaches 70%. That's exceedingly high mortality rate in any disease. In fact, it is higher than most cancers, save pancreatic and lung cancer. These are terrible statistics. So let's take a look then at the clinical evidence behind the use of dermaPACE. So we'll take a look at some level 1 evidence. In 2007, we undertook a double-blind, multi-center randomized controlled trial of dermaPACE. I was part of that. Our center was part of this trial. It was an extremely painful study to undertake because we were doubly blinded. Both the patient and ourselves were doubly blinded. And it took a while to gather up this many subjects. But when all said and done, there was some fairly dramatic results after 2 to 10 weeks of treatments. We had 90% wound area reduction at 6 weeks. And these results were obtained using inclusion criteria that included comorbidities that other investigations would have excluded right off the bat. And we'll take a look at those in a second. In 2018, these studies were peer-reviewed and validated. So, real-world results. This is an important aspect to look at the randomized controlled trials, the pivotal trials that in which the FDA gave approval for the use of dermaPACE in diabetic wounds. These subjects were real-life subjects, ones that we see every day. Obese patients. The average BMI was 32 or more. The majority of patients had uncontrolled blood sugars. Half of them were moderate to heavy smokers. And the kind of care that they got once they left our hands varied widely. Because in our hands, our home care service is excellent and provides exemplary care out in the field. But in other patients, in other locales in the States, for instance, the care was very sporadic, and often patients would have to do the dressings themselves. So the type of care that they received out in the field varied. Nevertheless, the results were spectacular. So let's take a look at some level 2 evidence. And this comes from my colleague, Dr. Wendy Cole out of Kent State University in Ohio. And she designed another randomized controlled study looking at diabetic wounds that included the same study population as our level 1 studies. She looked at not wound area reduction, but tissue oxygenation saturation in these chronic wounds. And what she found was that the use of weekly dermaPACE increased tissue oxygenation, and we'll look at her evidence for that in a sec, increased perfusion and capillary density, increased growth factors, cause a decrease in acute inflammation, and a 70% decrease in overall wound surface area after 5 weeks. It's a huge drop. And almost half of the patients completely closed in under 5 weeks. So this is a very promising, very impressive study by Dr. Cole. So this is what this is how she was measuring the effects of perfusion. So she took 15 subjects, small cohort, but nevertheless significant here, with a chronic diabetic wound that failed to close by 50% over 4 weeks, and that's the standard. That's the standard definition of a chronic wound. Particularly in the United States, where Medicare mandates this, so the payment is governed this way, but that's the definition. And they underwent 4 weekly treatments of dermaPACE. Now, their perfusion was measured by near-infrared spectroscopy. And this looked at, it's an imaging modality that essentially takes a picture but shows areas of variable perfusion. The results showed that all the wounds demonstrated a decrease in wound area, with 7 of them, or almost half of them, completely healing in 4 weeks. And all of the wounds displayed a statistically significant increase in tissue oxygenation. And as you can see on the left, pre-treatment, we had tissue oxygenation in the middle of the wound at 49%. Directly after treatment, had jumped up to 60%. These are all very impressive findings that are reproducible. So let's take a look at some clinical case studies here. So what kind of results were we expecting when we embarked on this trial? We weren't exactly sure, but certainly the types of patients that we were engaging in this trial were not ones that would typically be included in other studies. Here, in this particular case here, we have a patient with a chronic wound that had been present for many, many months prior. It is at a very difficult spot to unload on the heel at the glabrous junction between the tissue of the sole of the foot meeting the skin of the ankle. Very challenging wound to heal, difficult blood supply to sort out. This patient underwent weekly dermaPACE treatments, and within 8 weeks had closed, and not only closed, but as you can see in the bottom right corner, closed with excellent skin. And that's a very important aspect of healing. If one has a wound like this, but heals with total scarring leaves a very hard surface that calluses up very quickly and is apt to reulcerate equally fast. So here's another patient. This was a patient of ours at our center in this study. This was an 83-year-old woman with a past history of Charcot-neuroarthropathy that had become inactive, but had left her with a midfoot lateral column deformity. And this is a common deformity that we see in Charcot patients and is very difficult to unload and results very frequently in ulcerations. This patient underwent weekly dermaPACE treatments and within 11 visits had completely healed. And as you can see on the right, on the bottom right, again, the tissue is supple tissue, which is very unusual in these kinds of chronic wounds that go on to heal by secondary intention. They almost always heal with scarring as a primary feature, leaving that area very difficult to keep ulcer-free. In this particular woman, this was back in 2008, I believe, or 9, and she is still a patient of ours, and her foot is pristine and in a custom shoe, obviously, but she is walking and enjoying her life at now. She's only in her 90s. So this is another challenging kind of patient with distal diabetic ischemia. So this is microvascular ischemia, which led to the great toe coming off, and then the second and third digits becoming ischemic. The patient underwent revascularization surgery, and during that surgery, the vascular surgeon amputated those toes, but unfortunately did not primarily close this wound. Left the wound open, as they say, they left it open to drain, but really left it for the likes of us to deal with. Very, very challenging. I know that this wound presented to us after probably 4 months post-operatively, and we then enrolled him in the study and applied weekly dermaPACE treatments to this tissue, albeit 15 weeks of that, but we had excellent closure. And again, the skin a little bit more scarred, as you can see. But again, this patient remains ulcer-free after 10 years and has not had the other toes experience the same kind of ischemia. So this is tremendous results in very, very challenging patients. This is a different kind of wound in the heel. My colleague, Dr. Ana Sanchez in Texas, she encountered this patient who presented with a 4-month history of a posterior heel wound with a tremendous eschar over top of that. She used dermaPACE to help remove that eschar, and then attacked this very hypergranular ulcer tissue in the posterior heel with weekly dermaPACE treatments, and within 9 weeks had taken it down from 29 square centimeters down to 7 square centimeters, which is extremely impressive because not only did the size reduce, but the morphology of the wound changed completely to one that was never going to heal to one that was imminently going to heal. And we can all see that from the signs. It's gotten flat, the edges are flattened down and contiguous with the base, and are obviously cells are flowing onto that sort of activated wound bed. This is very encouraging. These are very encouraging results indeed. So this is another type of wound, and this is a paper that we produced trying to illustrate the effect of dermaPACE on incision line healing and peri-wound edema reduction. And we found that we took 2 fifth ray amputations and a 4-foot amputation and looked at the the effect on the incision line healing, and found that in that aspect, we had probably a 50% reduction in incision line healing time. And we also had subjectively a tremendous peri-wound edema reduction, which coincided, we think anyways, with the speeding up of the incision line, because by reducing the peri-wound edema, you reduce the tension on the incision line itself and on the sutures. We find this very useful, and we use this as a routine whenever we're doing operations. Now we went from Canada in Hamilton. Now we go down to Brazil, and we are looking at a wound that I think that we all have seen before. It's a pressure injury around the sacrum, exceedingly difficult when having evolved for a long time. These cases were all down or near to the sacrum, to the bone itself, and had many, many months of evolution and not much success in healing. Dermapaste was used again on a weekly basis on these wound beds, which allowed for a progression to prep for skin grafting and a full thickness graft. These are very difficult and very challenging wounds to graft, simply because the wound beds often never get prepped right, and the debility that is encumbered by the patient is huge. These patients, by the way, were in the ICU because of COVID. They were incapacitated, and they were sick enough as it was with COVID, but were made even worse with these wounds. By the use of dermapaste on a weekly basis, they were able to prep the wound to get it to granulate, to increase its vascularity, and then apply this full thickness graft. And as you can see, after the grafting was done, the application of dermapaste continued. And as you can see, in all the cases, all of the grafting took and assimilated into and blended with the skin to produce a very supple graft in an area that often doesn't take and doesn't accept the graft, or doesn't produce a solid, or rather a supple grafting site. And that is important because a supple graft is a resilient graft and can deal with shear, which is what's important there. So we go from Brazil to Italy to Dr. Cassino. This is a study by him in Italy looking at the effect of dermapaste on biofilm. We know that biofilm is extremely tenacious, very difficult to resolve, very difficult to remove, and really and interferes tremendously with the healing of chronic wounds. Dr. Cassino's small study, but demonstrated that all of these wounds had a huge increase in MMPs, and by the use of weekly dermapaste treatments allowed for the reduction of these MMPs a huge amount, with wound area reductions corresponding to 61, 80, and 82% at 1, 2, and 3 weeks. So this last case is a patient of ours. This is a completely different kind of wound, an immunological kind of wound called pyoderma gangrenosum. We know these wounds. They're rare-ish. They're very difficult to diagnose. Even experienced wound clinicians such as yourselves, it fools me all the time. This patient came in with a diabetic foot wound, and during the course of that treatment, he developed hairy cell leukemia. He landed in hospital for chemotherapy, and while he was getting treatment for that, he developed pyoderma on his shin. So while he was in hospital, and this is a huge, huge pyoderma, while in hospital, he received all of the immunologically mediated immunosuppressive therapy that you're supposed to get for pyoderma, and underwent all of those, but that had very little effect. So we started seeing him, as you can see, December of 2015. This was. Now you look here, it was October 2020. It's not much better. It's smaller, but not much better. And as you know, with pyoderma, you can't really touch it. You can't debride it because when you manipulate the wound bed like that, you cause it to get worse. All we were able to do really was to remove the thickened callus-like eschar around the wound margin and applied sort of benign kinds of treatments on the wound surface. And that really wasn't producing any demonstrable results until we started using dermaPACE. And when we started using dermaPACE, we started that, this was October 2020, and we started using dermaPACE in the January of 2021. And by May, we had this. And this was probably 75% wound area reduction with huge amounts of cell migration and epithelialization, as you can see right down the center. This was a huge, huge win for this patient who suffered tremendously and was essentially saved from a lower limb amputation. And we talk a little bit, we talk a lot about technology helping our patients, and really good quality wound care is really, really important for our patients. They suffer so much. And dermaPACE, as a unique treatment modality, has allowed our patients to go on to live relatively normal lives. And it may sound overly dramatic, but here in this last case with this pyoderma, this gentleman, his life was not fun, and he suffered so much and had tremendous relief with the dermaPACE, and his life was made immeasurably better by the introduction of this technology. So here he is. This is Brad, and this is Sophia Neto. It was one of my clinic nurses, wound nurses, applying the dermaPACE. And here, this is how it's done. You move the head kind of in a grid-like pattern, making sure you hit all the important areas. We were targeting in this application, we're trying to target the wound margins, as it's felt that in pyoderma in particular, the wound margins is where all the action is, and it's where you want to try to provide some immunosuppression or some anti-inflammatory action, and then running it over the wound bed itself to stimulate growth factor and granulation production, etc. From a metrics perspective, the treatment start to finish, we timed this one at 2,000 shocks, was about 11 minutes to administer the actual treatment, and we had him down at around 20 minutes from taking the dressings off to putting them back on after treatment. So I'd like to end with a huge thank you for listening, and I hope that that this has inspired you. I'd like to say that dermaPACE, we use dermaPACE in a way that like a child would, and is really the limits of the use of dermaPACE is only limited by your imagination and utilizing the features that you've seen today. I hope that others will come up with different ideas based on those features. As Professor Kuo said, shockwave isn't the only modality for doing, but it's one of the best, and it certainly is a huge step up from our normal armamentarium, and it's something that we are very excited about using. So I thank you again, and I I look forward to your questions.
Thanks, Dr. Mayer. And any question or comment from our audience? I think the shockwave, spatial thermal pace is the spatial treatment for diabetic foot is like a physical therapist. So that's a little bit different our path treatment modality. For example, such as hyperbaric oxygen, or even VAC or topical duration. So that's a new specific treatment method. So any want to ask Dr. Mayer for coordinate shockwave? If not, I will just first question to ask Dr. Mayer. Thanks your wonderful talk and also share your experience and especially some tough case for the treatment, not just for diabetic foot ulcer and also in sacral or pressure injury wound, and also the final case pyoderma granulosum is quite difficult case, and use a shockwave can has improved and also almost here to cure the wound. So my question is what is the timing you thinking to start to approach use the derma paste if the patient come to your clinic after you evaluation? What is the start you recommend the patient should use the derma paste shockwave treatment? And the other question is, your different case, the dosage and also the shot. You mentioned you around 2,000 shots for each patient, or it depends on the area, the biggest and size in each area. So how about your experience in the derma paste?
So just to answer that question is easy. So there's a chart that Sandy Way put out, which kind of gives you a good estimate on number of shocks per, number of shocks based on the wound size in square centimeters. It's very easy and easily read, and you just gauge it that way. To be honest, we kind of guessed at some of the things that we were using. We were using it early on, and they didn't have that. But again, on big wounds, you need more. We were going in sort of blocks of 1,000. So on the big wounds like the dermapace, or on the pyoderma, we were using 2,000. But on the vast majority of them, we were using 1,000 as a standard. So that's our experience. And I think that if you spoke to, I don't know, Professor, I don't know how you determine when you're using it, but it's often based on clinical experience. So the more you use it, the more you get a feel for it, and you get an understanding of how it might affect the tissue, different numbers of shocks on different types of tissue and size of wound. And the answer to your other question about when to use it, well, I think that probably early on, but practically speaking, you don't want to be using a kind of a cumbersome treatment modality, relatively speaking, like this when you're dealing with a relatively superficial small wound that we know will heal on its own with proper offloading, debridement, and the application of some kind of advanced treatment modality without any kind of other special modality. But larger wounds, we are starting very early. We generally like to see how the wound responds. So I'm not sure how you work in your clinic, but we want to know how the wound is going to respond to an initial debridement, because often they come in and they've not been debrided at all. So we want to see how that responds, to see how the tissue responds, and how it might respond to a treatment modality. And obviously, if we get good turnaround on that after one or two visits, well, we'll continue with that. But if we don't, then we start thinking about other modalities. And we would then turn to dermaPACE.
Thanks. Any question? 玉姐可以，有没有什么我会问一下
？Hello, I'm the nurse from Hong Kong. May I ask a question?
Yes.
Yes, I'm the wound nurse from Hong Kong. And can the shock wave directly apply to the wound, or any wound tissue is not suitable for applying the shock wave? And the second question is there any contraindication of using shock wave? Thank you.
So the type of tissue that you shouldn't use on that dermaPACE, if I got your question correctly, is our tissue, if it's too painful. So if the wound itself is painful, now ischemic wounds can be quite painful. We got around that. We developed an anesthetic cream that we would put onto the wound, and we were able to kind of get around that a bit. But some wounds are too painful to use it on, and if ischemic ones are one of those kinds. And you also probably don't want to be using it on exposed bone because it can pound away at the bone, and that's not comfortable. Contraindications, I'm just wondering what I'd have to defer that one to Susan. But I think that the major contraindications are malignancy, not to use it on a malignant wound or a suspected malignant wound, and in someone who's pregnant. I think that's what, yes. Those are the two absolutes.
So
Thank you very much.
I'd like to continue with your answer, Dr. Meyer. So contraindications would be pregnancies, malignancies, of course, patients who suffer from coagulopathic diseases like hemophilia, and as Dr. Meyer said, a wound that is extremely painful. For bone, it's not really contraindicated, but you would start by trying to build up supporting tissue, treating the peri-ulcer area. And anything else would be up to the judgment of the physician. And of course, SANUWAVE is supportive. We have many different studies, different types of studies, and evidence that we could use to support any physician's decision. Thank you.
Thank you very much.
I appreciate it.
Thanks, Susan answer and reply the question. And another any question to ask Dr. Mayer? I have another question. Is that if you find a wound still have some necrotic tissue, or even they have some dirty ischia in there, you need to debridement first, or you feel it's suitable to direct to apply the dermaPACE, or you can direct just debridement first immediately, or just wait and see till the wound has much better, and then start to use the dermaPACE.
Yeah, so that's a excellent question, because we don't think of dermaPACE as a debriding tool per se. It may, in one of the cases I showed Dr. Anna Sanchez's case of that heel wound. I didn't show the eschar, but she basically shook that eschar off of that tissue by using dermaPACE, but it's not a debriding tool. In our hands, we surgically debride as you would, and if we had necrotic tissue, we would be trying to prep the wound as best we could prior to using dermaPACE. We don't really feel that dermaPACE should be used on, devitalized, grossly devitalized tissue. You're going to have some of it in there, but really you want to be working on fully debrided tissue that doesn't have any gross necrotic elements in it.
So CellulWave recommends best practice guidelines before you apply dermaPACE, and that includes debridement in whichever method the physician feels is appropriate: surgical debridement, autolytic debridement, mechanical debridement. But we like to begin with a prepared wound bed.
And so thanks, Susan. That's a good point, because when you have so if you think about what it's trying to do, if you have a devitalized wound bed with necrotic tissue, this device does not bring back to life dead tissue. And inherent in that statement is that if you're to awaken, let's say, cytokines or growth hormones, they have to be expressed. So if you have a essentially dead wound bed, they're not going to be expressed. So you have to bring this wound bed back down to an acute phase where there's the potential for these elements to be expressed, these proteins, and then stimulate that with the dermaPACE. So these are the conceptual things that one should be thinking about when approaching a wound with the dermaPACE: is how is it going to work? What are we trying to do with it? What element of the wound are we trying to shift? So that is an important point.
Thanks, Dr. Mayer. Due to time limit, it's final to want you just the final question is you till now the United States only approve the shockwave can apply in the diabetic foot ulcer, but in the international some country they have a various indication to apply the shockwave therapy for not just the diabetic foot ulcer, they can also venous ulcer and some different feel the wounding region, or even some tendinitis, inflammatory response area. So what is your true experience for the future for the clinician to apply this shockwave for the future?
That's an excellent question too. You know, what's my prediction, or what do I see in the future? Well, like I said, I approached dermaPACE with this sort of childlike attitude, where I was really trying to utilize its basic effects and marry that with my imagination about what I wanted to do with the wounds. And I think that we've only scraped the surface of what this shockwave technology can do to our wounds. And I think that what we need is more case studies and more clinicians using it, and using their imagination as experienced wound clinicians would, to try to find different ways to use dermaPACE. And initially we started with straight wounds, and that was straightforward. But we did notice that we were using we noticed that the peri-wound edema was reduced on open wounds. So we then decided, well, let's try it on incision lines. And with that, we noticed that the incision lines healed. So this is a progression of our imagination moving forward and utilizing the device in that way. I see a very bright future for dermaPACE. Obviously, is doing very well, and we love it. But in other clinicians' hands, we may yet see many more indications come out.
Thanks so much. Due to time limit, I need to close this lunch symposium section. And in your side, should be at midnight. So thank you. Take time to join
Bedtime for me.
and give us a wonderful talk and share your experience. Thanks. Thank you so much.
You're very welcome. Thank you.
Thank you.
Just